Welcome to the 6th in our series of school webinars on the role of different AHPs or allied health professions. This webinar will take you through the role of the diagnostic radiographer, and we have 4 diagnostic radiographers talking about their roles. And this will be followed up by some information about entry requirements and routes into the profession from Holly at University of Suffolk. I'd be grateful if you could keep your cameras off for the web and cameras and microphones off for the webinar, and there'll be an opportunity for questions at the end. Please do write them in the chat or as you think of them. If you attend any of our webinars before, you'd have seen this slide, and AHPs are the 3rd largest clinical workforce in health and care, and in the main they are degree level professions and are professionally autonomous practitioners. There are currently 14 registrable titles for AHPs covering 15 specific roles. You'll notice in this slide that there are 16 professions, and that's because in the UK, prosthetists and orthotists are dual registered as one profession. There may be some professions that you've never heard of, and if you're interested in a career in health and care and you don't know what yet, I would encourage you to have a look at all of the AHP roles. AHPs provide system-wide care to assess, treat, diagnose and discharge patients from social care, housing, education and the independent and voluntary sectors. Through adopting a holistic approach to care, AHPs can help manage care throughout the life course from birth to death. However, that's not strictly true for diagnostic radiographers because their role extends beyond this. Some radiographers work in sonography, scanning babies before birth, and others can work in forensics, taking images after a person has died to assist with identifying the cause of death. And here's just a slide talking about the other webinars that we've got in the series. There's 2 more. I know 1 more after this, the role of the speech and language therapist, and that will be in February. And with that, I'm going to hand over to Pride. And I'm just going to stop sharing.
Thanks, Nick. I am going to share my slides, and while I bring my slides up, so my name is Pride and I work at ESNEFT, so I work cross-site between Colchester and Ipswich hospitals. I have been a diagnostic radiographer and I trained at the University of Suffolk, as most of us here on the call have. I now manage the medical imaging department at Colchester and Ipswich Hospital. Sorry, I'm just looking for my screen. There we are. So I know in November you would have had a webinar focusing on therapeutic radiographers. They, like us, are called radiographers, and we often get confused between the two professions. So we are diagnostic radiographers, and diagnostic radiographers use a variety of imaging modalities to produce images which either confirm the presence or absence of disease, injury or malfunction. So it could be that somebody has fallen over and we want to check whether they've injured their wrist or their ankle. They might have an x-ray, and depending on what the x-ray says, they might have a CT. So there's a different the modalities that will be used, or different ways in which we can look at that. And the therapeutic radiographers are generally the radiographers that cancer patients see for when they have their radiotherapy treatment, and they use higher doses of radiation than we do within diagnostic radiography. But on the whole, we both are patient-centered professionals who use state-of-the-art equipment, and there's a lot of science and technology behind that, and it's ever-changing as new technology is developed. And we always ensure that we're using ionizing radiation safely for our patients. So X-rays, the majority of people are quite familiar with X-rays. So they are part of the electromagnetic spectrum. We also do use gamma rays in radionuclide imaging or nuclear medicine, and other types of energies within the electromagnetic spectrum. But I just wanted to point out that as X-rays are the most common, this is where they kind of sit within the electromagnetic spectrum. Diagnostic radiographers use a variety of equipment. In the top left, so this one is a CT scanner. We use X-rays, ultrasound, MRI, and this is not limited to this slide. The images on this slide are not limited to everything that we use. There are other ways that we image patients as well, but some of these ways are more specialized. But this is generally what most imaging departments would have. They would have an X-ray department, a CT department, an MRI or an ultrasound department. So these are quite common. And in terms of the images that we tend to see in the top left, they are all different depending on the modality that has been used. So you can see the CT images in the top left, an X-ray, which is a 2D representation of the area, the body part that we're looking at. And then for ultrasound in the left here, the most commonly used reason for ultrasound, I guess, or most known, is for scanning babies, but we do scan other things. We can also scan abdomens. Sometimes we do scan soft tissues if there are lumps and bumps that patients might have, and we also have MRI. So all the images will be different depending on what we have used to view those images for that particular patient, or to take the images for that particular patient. We also work in a variety of places. In a hospital, we can go to the wards, so we can be at the patient's bedside if the patients are too unwell to come down to the department. We can also go to A&E or to resus if the patients are too unwell, again, to come down to the department. We have mobile imaging equipment that we can take with us. But this is generally limited to X-rays. However, there are some hospitals that may have, for example, a portable CT, but generally what you tend to get are portable X-ray machines. We can also go to theatre. It could be within our department in interventional radiology, or we can go up to general theatres to help during cases when patients are being operated on. And most of these might be patients who are having screws and nails put in if they've fractured their hips, their bones, depending, could be a football tackle that's gone wrong and someone's fractured their bone and they go to theatre. So the surgeons will use X-ray to guide where they're putting in the plates and the screws. We also have vans, and these vans can have services such as breast screening, for part of the National Breast Screening Service. You can have CTs within vans, you can have MRIs within vans as well. So where we can image patients from is really not limited, is determined by the space and capacity that we have. We did have a CT scanner on an ambulance at one point, and this was used for stroke patients. So again, it ensured that we were going to the patients, imaging the patients before they arrived in the departments, and the consultants would have determined the treatment options for that patient, ensuring that the patients are seen quicker and treated quicker so that they have a better outcome. We image a variety of people. I think Nick said in her introduction, within ultrasound, we can image patients from before they are born. We image newborn babies up to the elderly, even sometimes when patients are at end of life, or even during post-mortem, to find out the reasons why patients have died. And we work with a variety of other teams within the hospital as we tend to go around. I think the Society of Radiographer has got, they do say about 90% of patients will require some form of imaging within a hospital. So most patients will come through the radiology department at some point. So we are truly multidisciplinary in what we do, and we support a lot of other services. I think I've got colleagues on the call that will talk about specific modalities within this webinar. So I will leave it to them to follow on. Thank you. I'll stop sharing.
Thank you, Pride. Lovely introduction, as always. I'm going to hand over Pride to Anatida, who's a newly qualified radiographer who will talk about X-rays. Anatida.
Hello, my name is Anatida and I'm a diagnostic radiographer. I trained on the 2-year pre-registration master's course at Teesside University, and I've been working as a diagnostic radiographer for ESNEFT for 6 months now. And I'm going to tell you a little bit about the profession and how to get into it. So according to the Society of Radiographers, diagnostic radiographers provide a range of types of diagnostic imaging to enable screening services, imaging for the diagnoses of diseases and trauma, and to facilitate treatments that include curative, palliative, ongoing imaging, surveillance, and end-of-life interventions and care, and also forensic investigations. Next slide, please. So every day as a diagnostic radiographer is unique, and you meet a variety of different patients of all ages and walks of life who may have been admitted to the hospital in what we call inpatients or referred by their GP. There are many different types of things you may do in a day. At ESNEFT, you might start your day taking what we call plain film X-rays. And this might be in an inpatient department. This could include chest X-rays, hands, feet, shoulders, pelvises, spines, or even facial bones. I recommend Googling X-rays to find out more images online. So this is what an X-ray room looks like. So you have the table, which is where we put patients lying on their back to do X-rays. The machine hanging from the ceiling is the X-ray beam, and that's where the X-rays actually come out from and are produced. And then we have a stand towards the right, and that has the detector, and that's the actual board that collects the X-ray images to produce an image that we can actually see on our screens. We also have stands on the left-hand side, and that's to do weight-bearing X-rays. We can also do whole spine X-rays on there. And then we also have the green bucky in the back, and that's to do things like chest X-rays, facial bones, or spines. So later in the day, in a typical day, you might end up going to theatre, and this is the kind of machine that we use in theatre. So we call it a C-arm machine, and it has on the left-hand side the screen that shows the images to the doctor or the surgeon, and then the C-arm on the right-hand side is shaped like a C, with the X-ray beam at the bottom of the machine and the detector at the top that actually collects the images. There's then a smaller screen on the C-arm that the radiographer can use to look at the images that they're taking. So when you go up to theatre, you'll be working with a multidisciplinary team, and this would involve scrub nurses, doctors, ODPs, and theatre assistants. And this is what it might look like. So you have the patient on the table, and the doctor is operating on them. The C-arm goes over the patient, and the X-ray beam actually goes underneath the table, and beams go through the table, through the patient, and then onto the detector at the top, which is what you can see. So the radiographer in the background is the one taking the images, and they can see on their screen the images that they're also taking. And there's different levers that you can adjust the height and how far in the machine goes. So diagnostic radiography as a career offers the opportunity to go into many different modalities. When you qualify, like myself, you will start as a Band 5 diagnostic radiographer doing plain film X-ray, but you can progress into other roles that are band 6 and above in the NHS. For example, you could go into CT, which produces 3D diagnostic images using X-rays. You may go into MRI, which is magnetic resonance, or you might go into nuclear medicine or ultrasound, where you'd be doing baby scans or diagnostic ultrasound. So I hope you have a little bit more information about what the job entails, and maybe it's something that you'd be interested in applying for. So I'll pass on to my manager, Hayley Duffy, and she's going to talk a bit more about diagnostic radiography.
Hi, you get me for 2 bits, lucky you. So first of all, I'm going to talk about CT, which is computed tomography. So what you've got the picture of the gantry. The patient will lie on the bed and they'll go through the gantry, which is the big circle, and then on the other screen you can see what the radiographers see when they are working. Right, so a little bit of science. I'll try and keep this nice and quick. So the CT scanner uses X-rays and computer processing to create a detailed cross-sectional images within the body. So the patient lies on the table and it moves through the circular opening, which is called the gantry. So inside the gantry, there is the X-ray tube, which is like a normal X-ray tube, but then there's a row of detectors around it as well. And within that, it spins and the patient moves through as it spins. So, and what happens is the detectors measure how much radiation passes through the body. Different tissues, bone, muscle, organs, air, they absorb X-rays differently. The scanner collects thousands of measurements from all different angles, and then the computer uses these measurements to calculate and reconstruct detailed images, which are cross sections of the body, and then they combine them into a 3D view. Okay, so the data collected can be manipulated by changing the brightness and contrast to highlight specific tissues. This is called a CT window. It's based on something called a Hounsfield unit, which measures the tissue density. So the human body has a wide range of densities. If we show them all at once, the image will look unclear, and then by using different windows, it helps us focus on what matters. So we have the window width and the window level, which we can then manipulate different ways. So there are different windows to show different parts of the body, different organs on the same image. So here we've got exactly the same scan using different windows. So you've got a bone window, which enables us to see the bone really well, but then the organs aren't as well differentiated. And then you've got the soft tissue window, which actually then you can see the organs really well. And then you've also got a lung window, which you can't really see much at all. The image on its own, that is a lung window. So that's really, really good at specifically showing the lung tissue. So we can also use contrast media to further enhance the structures within the body to make them more visible. So contrast media changes how the X-rays interact with the tissues and make them stand out more. It can be used to highlight blood vessels and organs and to show abnormalities like tumours and blockages. And it can be injected by a cannula in the patient's arm, which the radiographer may insert. It can be taken orally, so they can just drink it, or it can be introduced directly into the area that it's needed. And CO2 or air can also be used as contrast. So I've got a few examples on the screen here. So the top image that says non-contrast and contrast, that is of the kidneys, and the first one is without the contrast, and the second one is with the contrast. So that's been injected intravenously, and the scan is timed so that the X-ray dye, the contrast, is in the right area to visualize that particular organ. The one below it is a CT head with and without the contrast, which again is intravenous. On the first image, you can't really see a lot, but on the second image, you've got highlighted blood vessels due to the introduction of the X-ray dye through a patient's cannula. The other image on the bottom left is of using CO2 for a CT pneumocolon. So this is something that is used to so you don't have to, normally a patient would have a colonoscopy, which would involve quite a large scope going into the patient, whereas with this we can just introduce a small tube and put some air in, and then the images can be reconstructed to have a 3D fly through, so you can see the whole bowel and you can fly through the images there. CT is something that is very widely available in the hospital now. It's quite quick to do. We have one in the ED department, and it's quite available. So uses of the CT in the hospital can be diagnosis. So trauma, cancer, stroke, infection, anytime the doctor is not sure what's going on, we can have a CT and we can see. It's used for treatment planning. So if you know there's something that a patient needs, then we can do it for surgical planning or prior to radiotherapy. And if you attended the radiotherapy ones, they would have talked to you about their planning of scans, planning of their treatment, and they quite often use CT for that, and they have them in their own departments. Monitoring, so it can be used to check cancer treatment or following vascular surgery. So if a patient's had a stent inserted in the vascular surgery, they want to check the patency of that. So they will have scans every year just to see what's going on. And also we've introduced screening. So we are now doing targeted lung health checks. So patients that have been smoking, they have a low dose CT scan just to catch any early signs of cancer. All of these reasons can be very worrying for patients, and as radiographers, it's important to make sure that the small amount of time that we spend with these patients is as stress-free as possible. The CT scan can be the first time that a patient enters the hospital and be the first experience they get of what can be a very long pathway. And if they have a bad experience with us, it can then affect the way that they feel about further trips to the hospital. So for me, I feel that radiographers, we don't have a long experience, long interaction with patients, but I think that our very, very small interaction can make a massive difference to them. And yeah, it's something that I feel that we do really well. And I think it's a really good opportunity to kind of engage with patients and make them feel much better about being in the hospital. That's CT. So next, I'm going to talk to you about interventional radiology, which is one of my passions. Interventional radiology, and this is the equipment that we use in there. So it's like a big C-arm that Anatida showed you earlier, but it's a fixed bit of equipment in our department, which has got it's got a table and it's got the C, but it is fixed and it's a lot more powerful and can show a lot more information than the ones that we take away to theatre. And then we've got our lovely control panel. You can see what the radiographer sees. So we have we can do lots of different things with the machine, that's the control panel there. So interventional radiology, it's quite wordy this, is a specialism within radiology which uses image guidance to perform minimally invasive procedures for diagnosis and treatment. So it's not just that bit of kit that I've shown you. It can be used in X-ray, which is that, CT, ultrasound, and MRI. It's kind of an umbrella term for lots of different things. We tend to use small incisions with needles rather than open surgery. So whereas someone might have needed a whole big operation before, we can actually treat them by using the X-rays without having quite such a big operation. It's often performed under local anaesthetic, which reduces recovery time. And often some patients are not suitable to have a general anaesthetic. So with us able to do these procedures under local anaesthetic means that we're able to treat more people that may not be able to be treated. So some common procedures include angioplasty or stenting, embolization, which is basically blocking off something that could be bleeding or causing any problems. Biopsies, so if a patient has a mass somewhere, what we can do is we can take a sample of that mass and then we can get it, it can then be looked under by the pathology team to see if there's anything wrong with that. We can do drainages, so if anybody has like a collection in their abdomen, we can put a drain in, or if their kidney's blocked, we can pop a tube directly into the patient's kidney to relieve that pressure. But this involves a team of staff, including doctors, nurses, radiographers, and sometimes external staff. So teamwork within interventional radiology is really, really important. So the doctors tend to be performing these procedures, and then it's the radiographer's job to get really, really good imaging. So the doctors can only do the procedure if they can see what they're doing well, and that's what I pride myself on doing, being able to see what they do. And when you've got a team that works so well together, you can kind of almost do the job without even talking. So I feel that I sometimes know what the radiologist wants before they know, and it's that I really, really love. And we also have joint cases, which are done with the surgical team and the interventional radiology team working together. So the next thing I'm going to explain is a procedure that we do, and this is a joint procedure with the vascular team. So first image you can see on the screen is actually a CT reconstruction of an abdominal aneurysm. So the big tube going down the centre of the body, that is the aorta, and it's got a big bulge. We've got the kidney as well, so we'll ignore the kidney, but it goes from quite narrow at the top and gets much wider and then goes narrow again. The vessels tend to kind of start off at one thickness. If anything gets thinner, if they bulge out, then there's a problem. The lining of the vessel wall gets weak and they can then rupture. So the next image in the middle, that is of an abdominal aneurysm. So you can see the X-ray dye in the middle of the big blob. That's the aneurysm. And then on the right side, you've got the CT image there, and that's the CT reconstruction of one image just to kind of see the aneurysm. Next. So the EVAR procedure. So what an EVAR is, an endovascular aneurysm repair. What the aim of the aneurysm repair is to kind of create a channel that the blood flow can go through, which means it isn't going into the aneurysm sac, the big bit that's sticking out. So what happens is the doctor sticks some wires up each patient's femoral artery, and they both go up the side, and then they introduce a stent. So the second image is starting to show the stent being deployed. The third image, you've got part of the stent in, but we need to get the second limb in. And then the last picture is all of the limbs in place. Okay, so these are some intraoperative images. So the first image is showing you the pre-EVAR angiogram. So this is an actual case that we've done. And then the first one, you can see you've got the contrast filling the aneurysm, and the iliac arteries, which are the two that have got the wires in at the bottom, they're not fully opacifying. You can't see them very well because what's happening is the blood is pooling in the aneurysm sac, so you're not getting good flow down the patient's leg. And on the second image, which is the post-EVAR angiogram, the contrast is no longer filling the aneurysm. It goes through the stents and into the iliac arteries. So what's happening now is that thin bit of the thin vessel wall is now not getting any blood supply to it. So that's really good, because if that really thin vessel wall ruptures, then you've got a lot of blood going into your abdomen, and this is really, really quite serious. These are procedures that we were doing a lot of these. If an aneurysm ruptures, a patient can die in minutes. So it's really important that we treat these, and we've now increased screening so that we can treat them in a much more timely manner, rather than getting called in the middle of the night for an emergency, to be a life-saving operation. And these are just examples of EVAR stents. So these are CT scans after they've had the stents put in, and there's all different types that can be put in. So the first one has got a single leg, and then it's got a crossover from their femoral arteries. The second one's a normal one, and then the third one is a very special type of stent, which is called a fenestrated stent. You've got lots of different blood vessels that come off your aorta, which is your main blood supply. And what we don't want to do is we don't want to block any of them off. So we have to have stents that are specially measured, that go into that then they have holes in certain places so that you can put stents in, you can maintain blood supply to that. And that is interventional radiology.
Thank you very much, Hayley and Anatina, for all of your passion for radiography. It shines through, and I've definitely learned something today. But thanks very much. With that, I'm going to hand over to Rose, who's a consultant radiographer and the Nuclear Medicine Service Manager at West Suffolk. Rose.
Thank you, and thank you for that talk. It was very good. So I'll be talking about the role of radiographers in nuclear medicine and a very brief description of what nuclear medicine is, as this may be something you've not heard of before. I wasn't aware of nuclear medicine until the placement to nuclear medicine in my second year of my diagnostic radiography degree. And I am quite biased, but I think it's important that you're aware of its existence prior to this and hopefully can start considering it as a career option. So what is nuclear medicine? New slide, please. It uses a small amount of radioactive material to diagnose, treat, and monitor disease. So what I've always found fascinating about the modality is we're looking at how things work rather than what they look like anatomically. This is called functional imaging. So we image slightly differently to other modalities. We image using radiopharmaceuticals, and this is different from other forms of radiography, where the machine, i.e. the X-ray tube, is the source of the radiation. For us, the patient becomes that radioactive source. The radiopharmaceutical has two components, a medicine, which will ensure that it goes to the area under investigation, and a radioisotope, which allows us to image this process. So the majority of departments will have a SPECT CT system these days. So that's like the one pictured here with Ted, the nuclear med Ted. And this allows us to get functional information from the nuclear medicine scan along with a CT for anatomical information. So this improves diagnostic confidence, and it can mean that the patient doesn't need further imaging. So this is called hybrid imaging and is an improvement in that patient care pathway. Next slide, please. So some common applications would be myocardial perfusion scans, which are a non-invasive test that evaluate the blood flow to the heart muscle. We also do different types of renal imaging, and these kidney scans are used for assessing renal function and drainage. For one type of kidney scan called a MAG3 scan, the radiopharmaceutical is given while the patient is on the table, and this is a dynamic study, and it allows us to see how each kidney performs and drains. The most common thing that we do in nuclear medicine at the moment would be the bone scan, and these are sensitive for detecting abnormalities in bone turnover and vascularity. So this means it can detect disease before structural changes become visible on X-ray or CT. We also might do thyroid scans, which evaluate the functional activity within the thyroid gland, amongst other indications, such as looking at size and shape of location of the thyroid tissue. So these are just a few of the applications of nuclear medicine. There are many more, all of which involve different processes and protocols, which helps to keep the job interesting. Next slide, please. So what is the role of the radiographer in this modality? So in the morning, we would come in and we'd perform QA, so this is quality assurance, before we start imaging any patients or administering any doses. So these are tests that make sure that our system is working. And then, of course, we provide patient care. We discuss procedures and make sure the patient is giving informed consent. To do this, we talk through the radiation risks and precautions for the studies that we're performing and answer any questions concerning those. We then administer the radiopharmaceuticals for the scan that we're performing. This may involve placing a cannula and administering the radiopharmaceutical whilst the patient is on the scanner, injecting intradermally, which means just under the skin, or even making up a meal such as scrambled egg or porridge, which is bound to a radiopharmaceutical. We use this to demonstrate the gastric emptying of the stomach, and it would produce images like those seen on the slide. You can vaguely see those in the background there. So we're seeing how the stomach is working. For studies like this, and many of the studies that we do, we'd also need to process this data. So this can be involved drawing regions of interest around certain organs or certain things that we're looking at. And this aids in the interpretation of the imaging. Next slide, please. Oh, sorry, I ran out of slides. I thought this was, sorry, nuclear medicine is interesting and diverse profession. So radiographers have many skills to perform this job, and they can also progress by doing things like being radiation protection supervisor, reporting nuclear medicine images, and other roles that can lead to advanced or consultant level practice. So thank you very much for listening. I hope this is something you'll consider in the future, and you could also always reach out to your local department for further information or see if you're able to visit.
Thank you very much, Rose. And with that, I'm going to hand over to Holly, who is the course leader at the University of Suffolk. Holly.
Lovely, thank you very much. So I love the way different radiographers have told you about different aspects of the career, because certainly that's something that really drew me to it. The fact that, you know, you could specialize in a particular area, or you could work in multiple different areas that mean that no day is the same. You meet a different patient every couple of minutes. And as Hayley said, that ability to build a rapport and make a difference in that short period of time is a really key skill for diagnostic radiographers. One of my friends who's a radiographer always says, you make a new friend every 5 minutes. And having those skills to do that is really important. So the University of Suffolk are the only provider of diagnostic radiography education locally. So thank you for inviting me to come and tell you a little bit about the course. Next slide, please. Lovely. So it is a Bachelor of Science degree. It's 3 years and it's full-time. And by full-time, we mean that you tend to be in the university setting 3 or 4 days a week, and on placement weeks you're in the hospital 4 days a week. So some students do have a part-time job to support their studies, but the majority of students, you know, it's quite busy, so it's a full-time degree. And at the university we apply what's called block and blend, and that's really important and works really well for diagnostic radiography, because it means you have periods of 6 to 12 weeks in academic, so attending lectures, workshops, doing practicals in the on-site X-ray room, so learning that theory before then going out into one of our hospital placements for a period of 6 to 8 weeks to apply that learning, to apply theory to real life situations where you meet real patients, you work with, you know, real qualified radiographers, and it's bringing that learning to life. So radiography often appeals to people who are quite practical learners and like to do. So it's quite an active degree. About 50% of the time across the course is spent in practice placement, and that's really, really important to build all those skills that mean when you qualify, you are ready to go and ready to look after those patients to the best of your ability. The employability for a diagnostic radiography degree is excellent. Our population are getting older, so I think it was Pride who mentioned that 90% of patients in hospital will have imaging, and that was a stat I was going to share with you as well, I must admit. So 90% of our patients coming into the hospital are requiring imaging, and with our population getting older, there are more people that we need to image. And then on top of that, our imaging modalities are getting better. We are getting better at picking up on different injuries, illnesses and diseases. So we have a real drive for more radiographers. So it's always important when you go to university that you have an idea of what you're going to use your degree for, in my opinion, and the employability is very good for radiography. Something I just wanted to note is that HCPC registration is essential as a radiographer. So you cannot work in the UK without being registered with the Health and Care Professions Council. And our course is approved by the HCPC, which means upon successful completion of the course, you're eligible to apply for registration. Next slide, please. Thank you very much. So although the University of Suffolk is based in Ipswich, we actually have 11 different hospitals that you could spend time at for your placement. And each of those hospitals have practice educators, so qualified radiographers who support, teach and assess students when they're on placement. And they're invaluable to your learning experience. So we have hospitals in Ipswich and Colchester, so part of SNEFT, and then West Suffolk Hospital in Bury St Edmunds, where Rose is from. But we also extend as far as the Norfolk and Norwich in Norwich, the James Paget Hospital in Great Yarmouth, the Queen Elizabeth Hospital in King's Lynn, And then going further west to Peterborough City Hospital in Peterborough, Addenbrooke's Hospital in Cambridge, and then down in Essex, along with Colchester, we have Broomfield Hospital in Chelmsford, Basildon and Southend hospitals. These hospitals vary in size and the number of students that they take each year. So, for example, Ipswich will take 8 students each year, whereas the Norfolk and Norwich, being a larger hospital, will take 14 students each year. So after your interview, if you choose to study radiography, we ask you to rank the hospitals in your order of preference, and we get you to think about things like, would I prefer to train at a large hospital or a smaller hospital? You know, do I want to be close to campus, or do I want to be closer to a family home that might be elsewhere? You know, we have some specialist hospitals in our region, so we really get you to think about where you would like to spend that time. And when you are on placement weeks, you'd undertake 30 hours of placement per week, which is usually 4 days. And that's to experience the shifts worked by qualified radiographers, so that when you are qualified yourself, you've got a really broad and effective knowledge base that you can draw upon. Next slide, please. Lovely. So one of the things I thought was really important to mention about healthcare professions courses. So if you choose to train to be a diagnostic radiographer, you can, as of the current time, and obviously I can't guarantee things won't change if you're watching this webinar in 3 or 4 years' time, but currently there is an NHS Learning Support Fund, and if you scan the QR code, it will take you to that page. And that NHS Learning Support Fund gives you £5,000 per academic year that you don't have to pay back. And that's to support you throughout your studies, because we need healthcare professionals in our NHS. Currently, diagnostic radiography is a shortage profession, so student diagnostic radiographers are actually getting an additional £1,000 a year on top of that as well. So, you know, if you're concerned about finances associated with university, which is a very important consideration to make, the NHS Learning Support Fund, as I say, is currently a total of £6,000 per year for diagnostic radiography, might just help you to be able to make that transition into studying for another 3 years. If you, I know we're going out to schools and colleges at the moment, but you know, so there might not be any parents amongst us, but if you are watching this webinar later and you're thinking, well, I've got children, how will I manage at university? There is also a payment of £2,000 per academic year that student diagnostic radiographers don't have to pay back if they've got children. And that's a one-off payment. It's not for every child that you've got. And the other important thing to think about is travel and dual accommodation expenses. So the NHS don't expect you to be out of pocket for excess costs associated with placement. So if it's costing you more to get to placement than it is to get to university, you can claim back that excess cost. So you'd pay for the train ticket or the accommodation in a different town, keep the receipts, and then you'd be able to claim those back, subject to some maximums. You can't stay in the Hilton, for example. But I think before, you know, when you're thinking about going to university, it is important that you consider the financial aspects, because we don't want students to struggle financially when they're studying. We want you to have time to, you know, to focus on learning and really enjoying your subject and making the most of your placement experiences. And therefore, the NHS Learning Support Fund is there to really support you to make the most of your studies. You don't pay this back as long as you are eligible for Student Finance England funding. So if you're eligible for Student Finance England funding, you'll be eligible for this as well. Next slide, please. Thank you. So a quick whistle-stop tour of entry criteria. So these are for September 2026. We don't envisage these changing, but obviously if you're applying or considering applying for a different year, you will need just to have a little chat with us at the university. So applications are made via UCAS, as they are for all university degree courses. and require a personal statement that tells us a little bit about why you would like to be a radiographer, and will require a reference from your school, college, or if you're in employment, your employer. So the minimum entry criteria are 3 GCSEs at grades A star to C or 4 to 9 in new money, including English, maths and science. Okay, we do accept level 2 equivalents as well, and if you're in any doubt or your entry criteria perhaps haven't, or your qualifications perhaps haven't been studied in England and they've been studied maybe in Ireland or something, you know, you can get in touch with us and we can check that they're equivalent. And then you would need to be aiming for a minimum of 112 UCAS tariff points. So that's equivalent to BBC at A level, distinction, merit in a BTEC extended diploma, or merit in a T level qualification. And we do accept a variety of those. So it might be that you did 2 A levels and a single BTEC, and therefore you've got a mix, and that's fine. What we're really looking for is seeing that you've got the ability to study at degree level, because all of the science is taught on the course itself. Any offers of a place would be subject to an interview and to, once starting the course, occupational health and disclosure and barring service checks, because you will be caring for vulnerable patients in an NHS hospital. Next slide, please. Lovely. So Anna Tida quite rightly pointed out that radiographers qualify onto what we call an NHS Band 5. And most of our graduates from the course will choose to go into the NHS at Band 5. And the salary at the time of chatting to you now is a starting salary of £31,049 a year. And that goes up to nearly 38,000 with some experience. Okay. And then you'll see that as you gain more experience, more seniority, there are opportunities to advance your career, as Rose mentioned, into various different modalities or management, which will bring with it increased responsibilities and increased salary. There are lots of opportunities for postgraduate study and to specialise. So there are postgraduate courses in breast imaging, MRI, nuclear medicine and ultrasound, just to name a few. And of course, there are also opportunities to advance your career in other directions. So we now have research radiographers working in the NHS. We have opportunities to work in education as a radiographer. So there's a real breadth of opportunities for future development and enjoyment within your career. And I think that's my last slide, except the following slide, which has just got my contact details on it. And that's just so that if anyone did want to email me because they had a query about a different qualification or something about studying radiography, they'd be able to contact me. Thank you very much, Nick.
Thank you very much, Holly, and thank you very much to everybody that has spoken today. Just for the people on the call, are there any questions before we close the webinar? Thank you very much, and we look forward to seeing you at the next one, which is in February. Take care, have a lovely afternoon.